Uh, with wave three peaked in mid-September and continues to decline. However, it appears that our daily case rates have recently plateaued. This is a phenomenon that has been seen in other states in the mid-Atlantic region as well as New England. The district's daily case rate has remained in this sort of range of 11 to 13 and a half cases per 100,000 since late October. And this translates to a weekly case rate range of about 80 to 90 cases per 100,000. And you can see here what that plateau looks like and compare it to where we were in November, October and November of last year before vaccines were available. During the peak of wave three, there was an increase in the number of new cases occurring in fully vaccinated persons, what we often refer to as our breakthrough cases. We did see this small increase for just quickly articulating it about a month ago. 1 in 7 new cases occurred in fully vaccinated people in DC. And recently that number has been more like 1 in 5 new cases occurring in fully vaccinated persons. This is a chart that we post on coronavirus.dc.gov under the Breakthrough Infections tab. You can see there that the blue indicates the cases that are occurring in fully vaccinated persons. It still remains significantly lower than the cases that are occurring in people who are not fully vaccinated, which we do currently break down in persons less than age 12 and persons greater than age 12. And those distinctions were made based on eligibility for vaccine coverage at the time. Despite the increase that we're seeing in breakthrough infections, we know that the vaccine is most effective in preventing severe illness, hospitalizations, and death. We have not seen an increase in the number or proportion of fully vaccinated persons who are hospitalized for COVID-19. Stated differently, what this means is that nearly 100% of COVID-19 related hospitalizations in the district over the past couple of weeks have occurred in unvaccinated persons, compared to about a month ago when still 90% of those COVID-19 related hospitalizations were occurring in unvaccinated persons. So this should really help people understand that fully vaccinated people have a much lower risk, even when they are infected with COVID, of being hospitalized, a substantially lower risk. And death from COVID-19 in a fully vaccinated person remains a rare event or occurrence in the District of Columbia. And when we review those cases, we find that people who are fully vaccinated and die from COVID-19 in the district typically are immunosuppressed or have a very complex medical history with multiple health conditions. So the main takeaway from our data trends that we've seen is that vaccination has been highly effective in preventing severe illness and death from COVID-19 in the District of Columbia, and we consider it our most effective tool in our toolkit in ending this pandemic. The key here is to make sure that people understand if you're fully vaccinated, while you may still have some risk of being infected for COVID-19, that risk is lower than unvaccinated persons. Unvaccinated persons still remain at the highest risk for COVID-19 in the District of Columbia. You have less of a risk of getting severe illness and dying from COVID-19 if you are in fact fully vaccinated, meaning that you have received 2 doses of the mRNA vaccine or 1 dose of J&J vaccine. So we have done a remarkable job in getting DC residents vaccinated. We've administered over 1 million doses of the vaccine since we began our vaccine efforts in mid-December of 2020. That means that 88% of all DC residents 18 and older have received at least 1 dose of the vaccine, and over 98.5% of all DC residents over 65 have received at least 1 dose of the vaccine. We have begun to vaccinate individuals who are 5 to 11 years old as of last week. And similar to all of the other vaccines that have been administered by many of our healthcare providers who take care of both DC residents as well as people who live in the region, We have administered over 5,000 doses. However, about 3,400 of those were to DC residents, which represents about 6.7% of the 5 to 11-year-old population. So we'll continue to make progress in increasing our vaccination rates. I'll emphasize again that vaccines remain our most effective tool in our toolkit for ending the pandemic here in DC. So thank you, Madam Mayor.
Thank you, Dr. Nesbitt, for that. So we want to move on quickly to what this means for our response. And as Dr. Nesbitt says, it can't be restated enough that vaccines are working. They're preventing people from getting severely ill and from dying from COVID. And we've come a long way in the past year. Vaccines are widespread and easily available as well. DC Health will be updating the health guidance, its health guidance, so that it is based on risk levels and the use of layered mitigation strategies. And risk levels will primarily be tied to a person's vaccination status. So in line with that approach, beginning on Monday, we will lift the current indoor mask mandate. Now, I want to be very clear. This does not mean that people should stop, that everyone needs to stop wearing their mask. But it does mean that we're shifting the government's response to providing you this risk-based information and recommending layering strategies as the best way to protect yourself and the community. And masks will still be required in some spaces, and so regardless of your vaccination status. And I'm going to list a few here. Any private business that wants a mask mandate may impose a mask mandate. On public transportations like buses and trains, inside train stations, in airports, and riding in shared vehicles, a mask will continue to be required. In schools, child care facilities, and libraries, a mask will continue to be required. In congregate facilities such as nursing homes, assisted living facilities, shelters, dorms or residences on campus, and correctional facilities, a mask will continue to be mandated. In a DC government facility where there's direct interaction between employees and the public, for example, at the DMV or DHS service centers, a mask will continue to be required. So obviously everyone who is eligible should get vaccinated because basically the positive trends that Dr. Nesbitt just went over are in regard to vaccinated people. But sadly, unvaccinated people are still getting sick from COVID and are still dying from COVID. Additionally, if you are eligible for a booster, you should get your booster. For example, if you received the Johnson & Johnson vaccine on or before September 15, 2021, you're booster eligible. If you received the Moderna or Pfizer vaccine on or before May 15, 2021, you're eligible if you're over 65, if you're 18 years and older with an underlying medical condition or a resident of a long-term care facility, or 18 to 64 years of age with increased risk for COVID exposure and transmission because of occupational or institutional settings. Here are all of the location, well, let me say, these are walk-up sites for vaccine for people 12 years and older. And we will continue to post this at coronavirus.dc.gov. If you have a child who is 5 years or older, take them to get vaccinated, just like little Carter, who is 5.5 years old, and he was one of the first DC children to get vaccinated at the Mary Center. And let me post now the pediatric sites for 5 to 11-year-olds. And you can see this is the weekly schedule. This is this week's schedule through Saturday the 20th. And you can also pull this down at coronavirus.dc.gov, where we have supported vaccine clinics. And Dr. Nesbitt, can you say more about where the other pediatric vaccine is available?
Sure. So we have available on coronavirus.dc.gov and the federalvaccines.gov site more information about the over 50 sites in the District of Columbia that are offering pediatric vaccines. Retail pharmacies are offering them at select locations. It's important to note that children are not small adults. And so there are some select locations that are specializing in the administration of pediatric vaccine to our young population. That's between the ages of 5 to 11. So it's important to visit these sites, to call ahead or to visit the website to make sure that they have the expertise in being able to vaccinate our youngest residents. We also have a number of private practices and large healthcare facilities that are also offering the pediatric vaccine to children between the ages of 5 to 11. It is a different vaccine than what is offered to adults. So it's always important to call ahead to find out if they are offering these vaccines by walk-up, like we are doing at the city-sponsored clinics that are listed there, or if they require an appointment. But there's plenty of supply here in the city, and we're excited to continue to work with our federal partners to be able to meet all of the demand that is coming from our parents, who we are excited to see that they are excited about getting their 5 to 11-year-olds vaccinated.
And furthermore, let me just say a bit about the vaccine requirements that we have in place in DC. First and foremost, there is a mandate for healthcare workers, any adult who regularly works in a school, and student athletes 12 and older to be vaccinated. Additionally, we have a vaccine or test requirement for other DC government workers, which we continue to work on, and we continue to support the Biden administration mandate for employers who have more than 100 workers to require mandates. And I'll turn to Kevin now to talk a little bit about our experience in DC government.
Thank you. So at the top of this slide, you see that healthcare workers, as the mayor mentioned, have a requirement to be vaccinated without a test out. Now that applies beyond just DC government workers. It includes 70,000 plus individuals who are licensed by DC Health. Now within DC government, you see Fire EMS, which is the agency most affected by the health worker mandate, which has a vaccination rate of 85%, and they have 293 individuals who are waiting for exemptions. The school employees are at 84% for all school-based staff, and they also continue to implement the vaccine mandate by issuing non-compliance notifications to those who have neither not requested an exemptions or are not vaccinated yet. And that process continues each week as we proceed, and we've seen an impact on the vaccination rates for those workers affected. You see the charter schools are at 93% of teachers and staff in response to the mandate for vaccination. DCPS is at 84%. I will note that for the full-time teaching staff, their vaccination rate is at 91% of their full-time staff that are fully or partially vaccinated. All these numbers will eventually move closer to 100% as individuals process their exemption requests or get vaccinated.
Okay, and next, I mentioned that DC Health would be updating its guidance documents, and they'll be working on that over the next days. And likewise, they will be updating tracking metrics that will be made publicly available. So Dr. Nesbitt, if you want to say a little bit about that.
Sure. Thank you, Madam Mayor. We've been before you on multiple occasions since March, or I believe it may have been February of 2020, to talk about the district's COVID-19 response. As we're here before you all today, I want to stress and emphasize that we are still in a global pandemic. It is not over, and we want to make sure that our residents have all of the information that they need to be able to understand their individual risk for COVID-19 based on their own exposures, their health status, as well as our risk as a community. You all will also recall that we've made changes to some of the data that we've publicly reported throughout the pandemic to be able to help people be able to better understand the risk, but also to help understand some of the policy decisions that were being made. As we move through various phases of the pandemic, there's a few different ways to move through phases of a pandemic. We want to be able to help people understand sort of the long-term strategies for monitoring infectious diseases that we expect will likely be endemic, always present in our community, sort of the same way that influenza is. So this next phase of public reporting for COVID-19 will help us do two things. One, shift metrics that will allow residents to assess and determine their individual risk as well as the risk in the community. And two, help us move to a pathway to monitoring and surveillance of COVID-19 in a manner that is similar to our process that we use for monitoring and surveillance of influenza. So when it comes to our ability to provide this data, you will see beginning on next Monday, the 22nd, a different set of metrics on coronavirus.dc.gov and a different set of data tabs on coronavirus.dc.gov. Some of the tabs will look different, and some of them will be very familiar to you. We will continue to post the daily case rate, which in public health is a great indicator of understanding the level of community transmission. Community transmission is a good way for public health to understand how much of a virus, a disease, an illness is actually present in the community. This is similar to what we use for flu. In flu, we use different categories to say minimal, low, moderate, high, and that's available on our website, the CDC's website, under sort of our influenza programs. So those thresholds will be there, but you'll notice a color coding switch from green to blue. Because we're no longer making decisions about the reopening of DC. So there will not be a reopening tab. These, again, are surveillance metrics that will help people be able to understand risk and understand how much virus is circulating in our community. The next thing that we will publicly report is helping to create more alignment between the daily case rate, which is a metric that was widely adopted by many public health agencies and reported in DC, months before the CDC created their 4 categories that aligned with a weekly case rate. Both of these metrics use a 7-day rolling average, but one computes based on the number of cases reported on a daily basis using a 7-day rolling average, and the other one uses a metric that's reported on a weekly basis based on a 7-day rolling average. We understand that we would find on some occasions some of our residents who would come to our site and see our daily case rate, and then visit the CDC site, use the numerical value, and say, oh, DC is really having low transmission, because the daily number being 5 cases per 100,000 is misconstrued as being a weekly case rate, which would be low, right? Which probably more aligns with, if it's a weekly case rate, you can go back to daily for me for a second so I can really illustrate this point. A daily case rate of 11.87 is equal to a weekly case rate of 80.78. So you can understand how much of an error it would create for someone to be able to see an 11.7 daily case rate and plug that into a risk stratification that's based on weekly and say, oh, we're in moderate. The other reason why we think it's important for us to have this weekly case rate is that the district, creating its daily case rate and our thresholds about 6 months before the CDC created the weekly case rate and its thresholds, had 3 categories, where on our daily case rate, our thresholds, we used minimal, moderate, and substantial. They don't completely align with the 4 thresholds that the CDC uses that are low, moderate, substantial, and high. There tends to be some overlap in our moderate group and the CDC's moderate and substantial. And so we want to be able to give our public both of those numbers so that whether you're referencing the DC group or you're referencing the CDC's criteria, you have accurate numerical statistics to use to be able to assess your risk. The next metric, I'll move through the rest of them pretty quickly, is percent of COVID-19 cases hospitalized. When we reviewed the previous trends, I was able to communicate to you all that in our subsequent waves 3, we had much lower rates of hospitalizations in the district in people who got COVID who subsequently were hospitalized. And so we'll be presenting that data to you all. So you can see now that if someone gets COVID in DC, the proportion of them who are actually hospitalized for COVID is low. And it was lower in wave 3 than in wave 1. We'll also be focusing our contact tracing in a much different way. We'll be prioritizing conducting contact tracing and disease investigation for high-risk cases. And those high-risk cases will be people who are at higher risk for severe illness, hospitalization, either based on age or information we have about their health condition. We want to make sure that we can direct them to therapeutics like monoclonal antibodies, and also for people who are in high-risk settings, such as child care facilities, schools, institutions of higher education, correctional facilities, long-term care facilities, et cetera. And then the last metric that we will be focusing on in our 6 core metrics are the percent of individuals who are fully vaccinated. And that, I think, goes without saying that our best tool in our toolkit of all of our layered mitigation strategies is vaccination. So we encourage you all as we go into the winter months is to be, 1, vaccinated, but to continue to use all the layered mitigation strategies that we know will add additional protection, such as wearing a mask, choosing all of your activities very wisely, using testing as a strategy before you travel. All of those things will help to remarkably reduce your risk. And speaking of testing, Madam Mayor.
Yes, thank you, Dr. Nesbitt, for that very detailed explanation of daily and weekly case rate. And I was asked last week, were we changing, or perhaps it was earlier this week, were we changing our testing regime? And I just want to let everybody know that we're not letting up on supporting testing in the district. And the citywide testing program can be referenced at testyourself.dc.gov. We continue to operate walk-up testing sites at rec centers, firehouse, and locations across the district. Finally, I was reminded today that next week is Thanksgiving, and we want to wish everybody certainly a happy Thanksgiving. Listen to some of the recommendations that Dr. Nesbitt made just now about travel and how you can protect yourself if you're considering travel, your locations, the vaccination status of the people around you, and the vulnerability of the people around you, and enjoy a happy Thanksgiving. I want to remind everybody that, of course, DC government is closed on Thursday, and I will announce that we will also be closed on the Friday after Thanksgiving in recognition of the very significant hard work that DC government employees have done over the last 20 months, not only fighting the pandemic, but in their return to work. So with that, we'll take your questions. Yes, ma'am. And Stephanie.
Mayor Bowser, why the change in government approach now? And is this now saying that enough people have been vaccinated that the district residents can start to move forward?
Well, I think we spent some time, Stephanie, talking about why now is the time for us to shift to a risk-based recommendations to the public so that they can make decisions about what's best for themselves and their families, and have a full understanding of the experience we have with the virus in our community.
Can I ask you then, DC's vaccination rate, I was looking at the numbers this morning, it's showing 63.1% of residents fully vaccinated. That is a lower figure than, say, neighboring Montgomery County that was showing 69.7% fully vaccinated. And Montgomery County is looking at likely reinstating their indoor mask mandate. So what does that say about what you're doing here in DC?
That says that more people should get vaccinated. I think you've heard me say in at least a quarter of our presentation today that we have a safe and effective vaccine. We have the vaccine now available to more people, talking about 5 to 11-year-olds. We see people in our community going to get those vaccines as well. And we're also telling people that we're not saying to anybody not to look at their own background and vulnerability and vaccination status and make decisions about when you should wear a mask. And we are also saying to employers, and I want to be very clear about this, whether you're a retailer, a restaurant, or office employer, that you have the ability to set the rules for your establishment, including vaccine requirement and including mask mandates.
So do you think Montgomery County government is going in the wrong direction then?
I don't work for Montgomery County. I speak for the residents of the district.
But they also come into the district, they're right next door, you have people going back and forth.
They come to the district right now. What is your point?
Your thoughts on the fact that they're going back with the.
I don't actually know what they're doing. Any other questions? Yes.
I assume this will take shape in a mayoral order at
Yes.
some point. And so a couple things that weren't mentioned that I'm wondering if you can just be specific about. Gyms, workout locations, yoga studios, places like that. Will the mask requirement be lifted for those establishments, and houses of worship as well? I don't know that they were enumerated in your list there.
Right. We talk about congregate facilities, schools, childcare facilities, libraries being exempt. So the gyms wouldn't fall into that category, neither would
You said exempt, but you meant still required.
still required.
So gyms would not be required.
They would not be required unless the proprietors require it.
And houses of worship, the same?
The same.
Okay, thank you.
Yes.
Now that you're making this decision, is there any change in thinking of implementing some sort of vaccine passport or actually a vaccine requirement for the general population above and beyond just DC government workers?
As I mentioned, we talked about who's required, the requirements that we have in place as a government. That's not just DC government workers, that include healthcare workers and all school personnel, and the federal mandate for employers over 100. DC Health can support residents who need, most people already have their vaccine cards. I think, Dr. Nesbitt, if you can talk about what we can give people if they don't have that card.
Sure. So thank you, Madam Mayor. So I think we've discussed quite a bit some of the challenges that exist nationally in exchanging information between state registries. Given that the district is extremely porous borders, I think all of you know the extent to which we've vaccinated residents who are not DC residents, the extent to which DC residents have been vaccinated in other states, particularly Maryland. We don't have a robust data set that allows us to create a digital vaccine card for all DC residents because they may have been vaccinated somewhere else. So it's difficult for us to produce a digital vaccine card for 100% of DC residents who have been vaccinated, regardless of the location where they've been vaccinated. They would have to contact the provider who vaccinated them to get proof of their vaccine status. Now, many of those providers are producing digital vaccine certificates that they can use, they can upload. Those things are already happening. We are working with our neighboring jurisdictions where the bulk of folks who were vaccinated outside of state were vaccinated to see what our options are for creating a digital solution. That notwithstanding, businesses can implement requirements. They can implement requirements for patrons to produce either their paper card or one of these digital vaccine cards and move forward with that process if they want to have 100% vaccinated events. I think some of us have attended those types of events and produced that type of record so that we don't prohibit that type of activity. But looking at it from an equity perspective, it's extremely difficult for me to recommend that in order to go to a restaurant or a sporting event in DC, that you have to produce this record when I cannot support all of DC residents in being able to get that support from its health department.
Yes.
Hi, is there any metric that would require the mandate to come back?
There is not a specific, and I'm glad you asked that question. And obviously, and as I explained the other day, DC Health is always monitoring the experience we have with COVID, especially if this virus changes and would require us to think about other emergency interventions that could include a mask mandate. So I want to be clear about something else, is that we're not suggesting that the numbers of COVID cases, the Dr. Nesbitt already said, we've been at a plateau for at least about a week. We're going into the winter months, and we can see those cases go up, just the way we've seen cases go up in other parts of the country already. So we have to be very focused on what that means for our public health system and our healthcare system. And Dr. Nesbitt and her team will be following any changes in the virus itself. So if we need to come back to the public and say, we think that we need to blunt transmission, or we see hospitalizations, or we see some other activity in the public health system, then we will come back to the public with that information. But hopefully that won't happen. And we have something to do about it not happening, and that's more people getting vaccinated who are eligible. Yes, Sam?
Yes, Mayor, and perhaps Deputy Mayor Donahue. There's still like 300 firefighters who are maintaining a religious exemption. Given that this is the only agency where there appears to be this trend, do you just accept it, or what are you doing?
It's a very good question. So there are, I think it's 251 firefighters who have asked for a religious exemption. It does not mean they get it. It's important that we deliberate carefully, because any denial we make, I assume, will get challenged and appealed. So we're very deliberative in the way in which we go about reviewing those exemption requests. Now, there are 7 members of FEMS who recently did have their healthcare license suspended by DC Health. And this week, FEMS will move to put those individuals on leave without pay pending termination. So what I've said in many venues is that all roads lead to vaccination or successfully having an approved exemption. And as part of my job is to make sure, as we go down that road, that the decisions that we make are able to withstand any legal challenge or appeal that happens later on. So we still have a number there, and I fully expect, if there are individuals who don't have their exemption approved, many of those, as we've seen elsewhere in the country, do go out and get a shot in the arm. And we just have to let the process play out and make sure we protect it from overturn and appeal.
And then they also refused to get a shot. So if you were denied and you got a shot, that would be acceptable.
If you don't have a pending exemption and you've not start the process to get a shot, then you lose your license with DC Health and you can't work operations. So, those numbers I hope don't creep up, but they might. But as we go through and review these exemption requests deliberatively, we'll start to see outcomes, and it's my hope, I know it's the chief's hope, that everyone gets vaccinated.
So at this point, 7 people have refused to get a shot and have been placed on leave without pay.
They will be imminently, but they recently had their license suspended. So that means they refused a shot and they do not have a pending exemption request.
Yes.
2 quick questions. Mayor Bowser, yesterday you used a term, and so did Dr. Nesbitt, that kind of slipped by some people. The term endemic. What is an endemic? Second of all, Dr. Nesbitt, in public health circles around the country, there's whispers that this may become like the flu shot, that we may have to get a COVID shot every year like the flu shot. Could you elaborate on that?
Sure. Thank you. Sure. So what it means to be endemic is that a disease or the virus, it exists among us, or it exists in specific populations. And so what, and I think some of you have heard the mayor say this before, is that we are learning to live with COVID, And the other part of that she says is that, the world is not necessarily set up for the unvaccinated anymore. And that's why we really want to stress how important it is to be fully vaccinated. So getting those first 2 doses of either Pfizer or Moderna, or getting that J&J vaccine is going to be critically important for people to stay out of the hospital, to not get really sick, and to be able to prevent deaths. So when we talk about something being endemic, it's really my way of trying to stress to people that we've moved away from this goal of getting to 0 cases of SARS-CoV-2 or COVID-19 in our community. And so it sets up how we think about the criteria that will be used globally to say we're moving out of the pandemic. We're not there yet, right? A pandemic it's broadly. It's not just about what happens here in DC, the National Capital Region, the US. This is a big thing. It's about what's happening across the world. So we really want to make sure that people are oriented to what we're expecting to happen with our data, how much we're chasing, getting to 0 cases every day, those things being a reality versus whether or not we're expecting this to behave like most respiratory viruses behave, which is we may see seasonal variation, even with the vaccine. So we may see lower numbers of cases in the spring and summer, and increases in cases in the fall and winter. So when I say endemic, it's more sort of creating those expectations around those trends. In terms of how often may we need a shot, how often may we need a vaccine, those discussions and deliberations are still going. So we had the phase 2 and 3 clinical trials, which brought the vaccines to bear, which meant we could all start getting our vaccines last December. And then there's additional trials that continue to help us understand if our immunity starts to decrease or wanes, which is what brought us the need for boosters. So additional studies will continue to help us understand if boosters start to wane and we need to get additional doses beyond that. So there's no clear answer to help us understand if you've been boosted, how long does that protection last, how good that protection is, the duration of that protection. So we'll still continue to monitor that and learn more. So the answer is it is feasible that it could be an annual vaccine that you have to get, given the experience that we saw with immunity waning around 6 to 8 months, but we simply don't know yet.
If we could get back to the medical license, Dr. Nesbitt, just to clarify, have you suspended the medical license, or have you revoked the medical license? And does it go beyond just the 7 firefighters? Have you taken action on any other medical license, whether they be DC government employees or just doctors and nurses or anyone else?
Sure. So it's a summary suspension of their EMS certification in the District of Columbia. So we have taken action on the EMS side of the house. For context, the EMS provider community is much smaller than the rest of the healthcare workforce. There's over 80,000 other licensed folks, and then there's our estimates are around maybe 25,000 of unlicensed, who we are also working through the process of. So everyone has gotten a non-compliance letter. Those letters started to move out. We find that many of the folks who are outside of the EMS system, not just FAMS, but the EMS system broadly, are still submitting their compliance information. So they may have reported to their employer who had a mandate, but failed to report to DC Health. So they're getting information into us. We're removing them from the list. We find that we have people who have a license, certification, or registration for any of the 70-plus health professions that we oversee, who no longer live in the district, haven't actively practiced in the district, and have just been holding on to that license just to have it, and they're communicating to us that they want to surrender. So we're working through all of that process. We will take enforcement action for them in the same way that we have for EMS, but the order of magnitude for that population is a lot larger. And those 19 health professional boards will be helping to move us through that process.
So do you have a number of how many non-compliance letters you've sent out to healthcare workers?
Probably around, let me get back to you on that, but I know it's in the thousands.
But no suspension as of yet?
Correct.
Anyone other than the 7 EMS
Correct.
workers?
Correct.
And I'm guessing, just from your previous comments, Mr. Donahue, that those 7 workers did not have exemptions pending and were not vaccinated?
That's correct.
Can they get vaccinated and come back to work?
If they get vaccinated before they're terminated, so we do give individuals it's important to note every setting has its own rules. It's often defined by its own particular collective bargaining agreement. In this case, the members will be placed on leave without pay, and they'll certainly have an opportunity to get vaccinated and get their license back.
Will they go through a trial board?
It depends on, I understand for the case of FEMS, the agreement they have with the union is to leave without pay and then proposed termination. The trial board question, I want to get back to you to make sure I get I don't misrepresent the process there.
Thank you.
Julie?
A few questions about metrics. First of all, in the changing the daily metrics, can you tell us why you're getting rid of some of these numbers that I think people have found useful, like the average test turnaround time or the % of hospital patients who have COVID?
So I will hesitate to respond to each one of them, but I'll use the ones you've mentioned as examples. So the district's test turnaround time has been less than 2 days for months. I'm not quite sure how useful it is to continue to tell the public that you'll get your test results in a day or 2 from any place that it's sent. The other thing is that the over-the-counter antigen test market is going to markedly increase in the next month or so. So having people know that if you get a PCR test, they already know in DC it's going to be a day or 2. Like, that laboratory capacity is markedly different than it has been. We've been out testing and outpacing the rest of the country for months. Not much movement there. Why continue to report it? Why have people fixate on something that's a non-issue and isn't indicative of our public health system capacity needing to be monitored in order to help guide our response, right? So it's this broader notion, Julie, of divorcing, helping to help people separate viewing these metrics from me needing to make a policy decision internally for public health or to make a recommendation to the mayor. The other one, when you look at the other one is more interesting, right? Because we're still having some internal discussions around it. The district's hospital capacity pre-COVID oscillates around 80-85%. That's what it's been doing for the last year, right? So no need for us to keep our eye on that. In fact, one of the core functions of HEPRA, and I know you all know Mr. Ashley very well. He's our Senior Deputy Director for the Health Emergency Preparedness and Response Administration. Outside of COVID, one of the core functions of his administration is to monitor the functions and capacity of our healthcare infrastructure to make sure we can respond to an emergency, whether it be a pandemic, whether it be a mass casualty event, that results as an act of bioterrorism or any of those things. So we keep our eye on that as a part of our daily work. So we're not going to take our eye off the ball for that. How useful that is, again, to keep measuring when it's been through wave 2, through wave 3, the same as it was pre-COVID, not really useful. So then you start having this conversation and you say, if we're really trying to help individuals assess their individual risk, as well as residents, visitors, businesses understand their individual risk as well as their risk of the community, is it more helpful for them to understand, if I get COVID, what's the likelihood that I'll end up in the hospital? Or is it helpful for them to understand what proportion of all of the people who are in the hospital, what proportion of them have COVID? Which one is more useful? Well, it's likely if you're trying to get people to understand their COVID risk and their risk of severe illness and hospitalization, it's more useful for them to know if I get COVID, what's the likelihood that I'll end up in the hospital, right? So that's the percentage of new cases that are hospitalized. That's the metric that we're shifting to. Less useful in terms of understanding your individual and community risk to know the proportion of all of the people who are in the hospital for heart attacks, strokes, elective surgeries, et cetera. What proportion of them are in the hospital for COVID? Now, for me, the reason why it's helpful for me is it gives me some understanding of how intensive the resource utilization is in the healthcare system. But again, that's kind of folding inward again during sort of the day-to-day core work of the health department. So how much of that needs to be made visible long-term on a day-to-day basis in perpetuity, or are we shifting to more of like what we do for flu versus how we were acutely focused on, public reporting for COVID initially?
Thank you. That was an incredibly helpful explanation.
Mhm.
Can I follow up on a couple of things you said?
Sure.
First, you talked about the difference between the external metrics and the internal metrics. To clarify that, can you tell us what some of those internal metrics were that helped you reach this decision that now is the time to end the mask mandate?
I think the mayor has talked about that at length.
Okay.
I've already gone over some trends.
Okay, and second, I liked what you said about, the world is not set up for the unvaccinated now, the way that it used to be. How should parents whose kids aren't vaccinated yet think about that when they're entering a world where their kids are unvaccinated and maybe the world?
If they're over 5, they should get them vaccinated, Julie.
What about?
Tell them I said that.
What about?
Well, let me just speak
If
for-
they're less than
hold
5,
on.
I really think, if they're less than 5, I think that people really have to think about the same ways that let's contextualize what it means to have children who are less than 5, right? And what proportion of our population that is. It's a small proportion of the population. And I think that we still have to recognize, right? That's why we're kind of in this hybrid space of saying we're not completely back to how our behavior was pre-COVID, because there are families who engage in community. There are parents who work outside of the household who have children who are under 5. And that's why it's important to use those layered mitigation strategies. If you have small children who are at home, if you have immunocompromised people who live in your home, if you have people who have chronic health conditions, you need to add as many of those layered mitigation strategies as possible to be able to protect those folks who are not yet eligible for vaccination or for whom vaccines may not be as effective, right? So those immunocompromised persons. And that's what we mean by saying our individual and community level risks, really being able to interpret those and understand them. We're very optimistic that the day will come that we will have vaccines for everybody over the age of 6. We want,
6 months.
6 months, thank you, the age of 6 months. To be able to have protection for everyone. We're going to get there. The getting for everyone over 5 was critically important. But we also have to make sure that if you're a household and you've got a 6-month-old and a 5-year-old who's going to school, we want to make sure you're doing the best for that 6-month-old by getting that 5-year-old vaccinated.
Any other questions? Yes.
Could we talk about the situation in schools right now? How has that been going? And are you hopeful that the school year won't be facing interruptions or any great challenges?
I think that our school community has done an incredible job. I don't have the numbers right in front of me. Dr. Nesbitt or Kevin might be able to tell you. But my last briefing on testing was that OSCE was at about 13% of the population weekly. Does that sound right? With a goal of getting to 20%. So our capacity around testing is very good. Our test positivity is very low. It continues to be very low. We have a manageable, we think, number of children or staff who are in quarantine day to day. We like to see that number go down. And that number can go down with more children getting vaccinated because there is no need to quarantine if you're a vaccinated student. So we feel very good about it. We know a lot of people have worked very hard, the school leadership, teachers, parents, and the kids. I mean, these kids are doing what we asked them to do. They're wearing their mask. They're following the instructions of their teachers. and they're doing what needs to be done so that they can be in school, and they're happy to be in school. Okay, we'll take one more round. Sam, and then Julie, and then Martin and Mark.
I'd like to ask about the homicide rate in the city. I'm not sure if it surpassed last year. I saw a homicide I wasn't aware of this morning. But obviously it's something concerning. Do you have anything to say about it? I guess we got 45 days left.
Well, we don't just have 45 days left. We have days upon days upon days left. So we're obviously very concerned about the increased number of people who've lost their lives senselessly in the district. And we are literally throwing every resource that we have at it, from police and fall crime initiatives to building blocks to pilot programs that this new budget is funding in communities throughout the district. We do think that the increased presence with the fall crime initiative areas is working. And we continue to work with our partners in the whole public safety ecosystem to make sure that people who are using guns are being held accountable.
So, Mayor, how do you determine if it's effective? Because you talked about the fall crime initiative, and I know there was a homicide in the one in Ward 7. I heard the shots of one in Ward 1.
Well, we look, Sam, and it is a very objective statistics. Are there fewer gunshots or shooting victims? And is there less homicide? And we look at the arrest, and we look at a number of statistics, and I can have the chief give you that briefing.
And the various organizations that you've gotten in place, from building blocks to violence interrupters, are you satisfied with the progress they're making?
Well, let me just say this. Building blocks is, I feel like we are experiencing a acute uptick. And there are strategies for working where there are intense areas or hot spots of crime, and it's an acute uptick. Those are not going to be the kind of the long-term building blocks initiatives. Those initiatives are going to take time to focus on the areas and the people who are causing problems. And the police are there for the acute issues where we know that we have individuals who are shooting guns and engaged in other violent acts or illegal acts.
And violence interrupters?
And?
Well, you talked about building blocks,
Yep.
I thought.
Well, building blocks is part of our non-law enforcement strategies, which includes our ONE's office and violence interrupters, which have had a little bit longer runway in the district, probably 5 years, 4 years. And they continue to work in communities.
Do you feel that they're having an impact?
I don't think anybody is satisfied as long as we have groups of people who are getting into gun violence. And that goes for all of our interventions, law enforcement and non-law enforcement alike.
Dr. Nesbitt, I wanted to ask about Thomas Farley. Were you aware of his decisions regarding the MOVE bombing victims and the vaccination campaign in Philadelphia when you decided to hire him?
Yes.
Can you tell us your response to people who say that those are concerning to them as he comes to work in D.C.?
Thank you, Zoe. I'm excited to have Dr. Farley join our team here at DC Health as one of our senior deputy directors. I'm sure you all know that it is a challenging time for public health around the nation as we experience a tremendous amount of a need to recruit a public health workforce that is not only talented but has the type of experience that we need to not only help us deal with the pandemic at this phase, but also to help us as we approach the challenges that many of our communities will have in a post-pandemic environment. So being able to recruit someone who has served as a health commissioner in 2 major cities is something that I look forward to being able to have him get to know many of the residents in the District of Columbia, and many of them getting to know him as well.
Martin and Mark.
Just quickly to circle back, since there's still been kind of continuing news about the situation at the DC jail, is there any update on leadership at the Department of Corrections? Is Quincy Booth still on personal leave? Is he still employed by the city?
He is.
So he's back from leave and he's still employed by the city?
I don't know if he's on, I don't know if he's on leave.
He is actively working, still the director of the agency.
All right, and then one last quick question. Last week at a council hearing, Attorney General Carl Racine had some pretty critical comments of the administration's, I guess the way he termed it, just in its lack of focus on the jail, or kind of focus on spending money to either fix the jail or build a new one. What's your response to what he had to say?
I don't have any response. It was, I think that the Attorney General unfortunately has veered into a political figure only. And that's unfortunate given that he's my lawyer and the district's lawyer. Yes.
Mayor, I know, I just still want to ask one question. We heard from Deputy Mayor.
But it's not your turn.
I thought you
It's
just
Mark's
recognized-
turn.
Oh, I thought you did, sorry.
Mark can give you his turn.
Okay, thank you, Mark. Anyway, Deputy Mayor Geldart last week talked about how many people had left the jail and gone to Lewisburg, Pennsylvania, and he expressed some hope that maybe at that point it would not continue. And I'm just curious, is it continuing? How many of the 400 have left the city, or do you know?
My understanding is about 100, give or take a dozen, were moved, that it did not continue in any numbers after the MOU was signed with the U.S. Marshals that allows them to be part of the team undergoing the monitoring of conditions and the remediation plan for it.
So the majority of the prisoners are still here in D.C.?
Yes, certainly the last briefing I got on it, yes, they're still here.
Right, and Sam, you give me the opportunity now to, like, Martin asked me a specific question, but what I should have said is all that we've done to make sure that we're addressing any concerns at the jail, which we take very seriously. And we have put together the city administrator, the deputy mayor Geldart, a team of officials, and an agreement with the United States Marshals so that there is an independent, somewhat independent look at those conditions. None of us would say that the pandemic in a congregate lockdown jail facility has been easy. I don't think anybody who runs a jail would say that. And some of the operational changes that we had to make to prevent the outbreak of COVID, which we have not had an outbreak of COVID at DC jail, also makes being in jail and being in the jail for a guard and the inmates very hard. And I firmly believe that some of the issues that we have at the jail right now have to do with that. Human beings locked down, guards stretched thin, and less to do with the facility, as some have noted. We do have an older facility. We have had a lot of community discussions about replacing that facility. We will continue to do that. But I feel very certain that when we can get back to how the jail was before the pandemic, when there was more freedom of movement in the jail, the lawyers having more direct access in the jail, more movement from, you know, the vocational programs where the inmates could go out of their normal living facility to take advantage of and be outside and take advantage of that. I know the operations will improve there. I was at the jail before the pandemic where we were celebrating a program where our inmates were studying for college degrees in various partnerships. You may have been there with me. We were a number of officials went to the jail that day. And so we know that our operations, when they get back to normal, when COVID inside the jail is less of a threat, we know that conditions will improve. Yes, Mark.
I'm just wondering about bringing the mask mandate back. What might have to happen to see the mask mandate return? Is there a metric that you're looking at, Dr. Nesbitt? And then, Mayor Bowser, are you also considering expanding the vaccine mask mandate to any government workers or any other class of people?
We, of course, we know that we have a test out option for DC government employees that is not optimal. And if I saw that moving, that it would be moving in that direction for the remainder of DC government employees.
So you're considering expanding the vaccine requirement without a test out option for all DC government employees?
That would be a logical next step for us.
And then how about what would have to happen for you or Dr. Nesbitt to want to reinstate the mask mandate?
I think Dr. Nesbitt has already talked about what DC Health will have to monitor. And hopefully none of us get to where we need to reinstate the mask mandate, but our public health system has to be able to, and our healthcare system has to be able to perform. And we'll be looking closely at that. All right, thank you, everybody.
We now return to our previously scheduled program, already in progress.